Today, it is my job to talk about three specific mutations, so ALK, ROS1, and RET, and we're going to talk a little bit about pushing the boundaries of targeted therapies. Here are my disclosures. And so today I'm really going to try to focus on what I consider to be today's best targeted therapy available for each of these mutations. You've heard from several of my amazing colleagues earlier this morning about some of these mutations. They've been mentioned by name. Some of these drugs have been mentioned by name. It can be really easy in this space to get lost in 10 different clinical trials and options. So I've chosen to really try to focus on what I consider the standard of care based off of what data we have available. So we're going to start first with ALK. And so ALK inhibitors have really been available to patients outside of clinical trials for about 15 years now, since the first approval of crizotinib. Since that time, we've also seen approvals for ceritinib, alectinib, and brigatinib, and then most recently, lorlatinib. And we've had some time for some of the lorlatinib data to mature. And so we're going to take a look at some of that updated data of lorlatinib. This was presented by Dr. Jessica Lin at last year's ASCO. So one of the things that we talk about quite a bit for different TKIs or tyrosine kinase inhibitors is what generation are they? And when we use those terms, really what we're referring to is what's captured down on the bottom in this triangle. So with each new generation of tyrosine kinase inhibitors, we expect to see increased potency, meaning increased activity or getting in and blocking whatever that mutation is at a better rate. We expect increased selectivity. And what we mean is that it's avoiding some of the other normal tissue and hopefully decreasing toxicity that we can see with each generation. These TKIs are designed intentionally to get into the brain better. You heard a lot about that in the last session about the importance of coverage of the brain space, of treating brain metastasis, and the ability to delay radiation to many of these spots of cancer in the brain. And then additionally covering some of the resistance mutations that can occur. And so we know that when we use TKIs, new on-target resistance mutations can develop. And what that means is if you are on osimertinib, which is an EGFR TKI, you can get new mutations on EGFR that can outsmart that osimertinib. By covering a larger number of those on-target resistance mutations, typically we can either treat them if they've already developed or prevent them from developing in the first place, which I think is really the ultimate goal, to get the best drug to the most patients earlier.